So I'd like to introduce our next speaker this afternoon. It's Rachel Buckle. She is a specialist gastroenterology dietitian here in Sheffield and also a trainee advanced clinical practitioner. She obtained her dietetic degree from Plymouth University in 2017 and she's currently undertaking a master's in advanced clinical practice. She has also recently become a supplementary prescriber and she's an advocate for advanced practice within dietetics. So I'd like to welcome Rachel to the stage with her fantastic talk on the National Survey of GI Dietetics Provision.
Thank you for the introduction. So today I'm going to talk about the dietetic provision in gastroenterology. So in particular, our survey looking at dietetic provision. So firstly, why was this needed? So we know that there's increasing demand in gastroenterology services with increasing prevalence of inflammatory bowel disease, increasing incidence and prevalence of celiac disease, and high rates of irritable bowel syndrome within the global population. These are all conditions which require dietetic input, but do we have the services needed to give adequate dietetic input to all of these patients? Well, that's what we set out to explore. So what was already known about this topic? Well, in 2007, a survey was done looking at the provision for dietitians in celiac disease, and they did found that the provision was only around a third of what was recommended in the British Society of Gastroenterology guidance at that time. Services were further evaluated in 2014 with a survey looking at management of Crohn's disease, but actually they looked a little bit more widely at hours and time allocated to dietitians in gastroenterology and found that actually only 23% of services met the identified standards for time allocated to gastroenterology dietetics. So, can we compare this to other professions? How do we know about growth of services in gastroenterology in general? Well, if you look at the number of gastroenterologists and hepatologists in England, you can see an increase in services, and it works out about 5% year on year for the past 10 years. So there is a growth. It's worth noting that this still doesn't meet the recommendations from the Royal College of Physicians in terms of numbers, but you can see a steady growth there. But can we compare this to growth in gastroenterology dietetics? Well, we don't really know. We don't create regular numbers, as far as I'm aware, to collect numbers of gastroenterology dietitians. We do know how many dietitians are registered with the Healthcare Professions Council, and we can see an increase in numbers over a similar period. But it does work out as a slower growth rate, so around 3.75%. We don't know how many of these are allocated to gastroenterology. We do know that membership of the Gastroenterology Specialist Group for the British Dietetic Association is increasing at a faster rate than this. But does this represent dietitians involved in gastroenterology roles, or does this just represent that gastrointestinal conditions are so prevalent that more and more dietitians are coming across them and want more information about them in practice and have more interest? We don't know. So, we looked to do a national survey evaluating the provision for gastroenterology dietetic services in England. We approached all trusts in England who had a gastroenterology dietetic service, so that was 158 trusts, and we got a 78% response rate. The response rate didn't differ significantly by region, so with a high response rate and no significant difference across the country, it's likely to be an accurate representation of the services that we provide. We asked about time allocated to gastrointestinal conditions, we asked about waiting times and modality of delivery of services, as well as management of services as well. So firstly, what did we find? Well, we found that there's a difference in the number of dietitians across the country. So we looked at full-time equivalents per 100,000 of the population, and there was a significant difference between regions. You can see the highest provision being in the North East and Yorkshire, and then the lowest being in North West at 2.16 per 100,000 of the population. The average across the country was 3.64 per 100,000 of the population. And if we look back at what's been done previously, in 2007, they identified about 5.2 full-time equivalents per 100,000 of the population at that period. Now, that was across the UK, so may be affected by provision in other areas, but it certainly doesn't sound like things are getting better. If anything, it sounds like they might be getting worse, but we don't take regular stock, so it's difficult for us to assess. So, we also found differences in service delivery and management. We found a differing number of trusts using policies for management of dietetic care for these patients, with about half of trusts using a policy for the management of celiac disease and irritable bowel syndrome, but only about 24% using policies for the management of inflammatory bowel disease. So this is important because previously identified use of policy for dietetic management has been identified to be associated with increased allocated time to dietetics for that condition and also increased presence of a multidisciplinary team. We also found differing access to specialist services. So about half of trusts had access to a specialist celiac disease or irritable bowel syndrome clinic. So that's a clinic solely allocated to that one condition, so a clinic where people can be seen in a specialist service. Now, we found that only 28% of trusts had a specialist clinic for inflammatory bowel disease. So that's a much lower percentage there, but still very variable access across the country. So we also found that timing of these specialist clinics differed, with the most frequent specialist clinic being weekly. So to put this into to raise a point here, so 72% of trusts don't have access to a specialist inflammatory bowel disease dietetic clinic, but of those that do, that 28%, it's most likely to be happening frequently. It seems like, from looking at that data, that would represent a real inequity in care and would mean that patients with inflammatory bowel disease across the country are going to have very different experiences in accessing dietetic management. We also found that different conditions are likely to be waiting different lengths of time for access to management, with patients with celiac disease and inflammatory bowel disease most frequently waiting less than 2 months. However, patients with irritable bowel syndrome are likely to wait longer for their appointment, with the most common waiting time between 2 and 4 months. So what does this mean for patients with irritable bowel syndrome? Well, many irritable bowel syndrome patients will have already identified dietary triggers for their symptoms. Over 80% is estimated. And many, so over 2/3 in this study, will be using dietary restrictions already to help manage their symptoms. But if they've got longer waiting times, without management for their symptoms, and without adequate support to implement these dietary therapies, they may be implementing them themselves, which in recent papers that have been published by Tuck and colleagues, which my colleague Christian's already talked about today and highlighted, really important paper that looked at how people are using this information that's been given about the low FODMAP diet. So they found that patients who see a dietitian are more likely to meet that therapeutic level for FODMAP reduction, so that 12-gram level that's quoted as a sort of therapeutic level. And actually, they're more likely to follow all 3 phases of the diet appropriately. So they're more likely to reintroduce and personalise their diet appropriately. So when we look at consultation time, we think about, well, what happens when the patient comes to see the dietitian? Do they get sufficient time with them? Well, it seems unlikely. So the most common consultation time was between 15 and 30 minutes, and actually advocated for in the literature is 45 to 60 minutes to deliver that initial low FODMAP consultation, so to adequately educate a patient on that elimination phase. So even when they get to see the dietitian, they're probably not getting enough time with them. So how does this compare to any standards? Can we compare this? Can we use any benchmarks to assess whether we have adequate provision? It would seem like from the data that we didn't, but if we have a look at standards, there's not really any clear numbers that we can use in terms of hours allocated for dietetics or numbers of dietitians required to deliver services for patients with irritable bowel syndrome. It is noted that within the guidance from the British Society of Gastroenterology that it should be supervised by a dietitian if the patient is going to trial the low FODMAP diet. As part of the guidance that the low FODMAP diet should be used as second-line dietary advice, a dietitian should be accessible to these patients. It's noted in the NICE guidance as well that a healthcare professional with expertise in dietary management should be delivering this advice, and that would seem logical that that would be a dietitian. So, when we look at inflammatory bowel disease, how do things compare? Well, the British Society of Gastroenterology guidance advocates for a dietitian to be a core member of the MDT for a patient with inflammatory bowel disease. And they do make recommendations in terms of guidance for how many dietitians should, or time allocated to gastroenterology. Now, actually, what supports our data for inadequate provision is a recent report they issued looking at over 72% of inflammatory bowel disease services, and also patient data from over 10,000 patients with Crohn's and colitis. And they used a benchmark of 1 whole-time equivalent per 250,000 of the population in terms of dietitians allocated to gastroenterology. And they found that only 7% of services actually had adequate provision for a dietitian based on this data. Now, this is reflected in patient reports, with only 43% of patients saying they had access to specialist support with diet and nutrition should they want it. Now, this is a patient group that are interested in diet and nutrition. They see it as a priority within their care. And they're looking for that information, with the Crohn's and Colitis UK food leaflet being one of their most downloaded resources. So when we look at celiac disease, another condition we sort of looked at, it's advocated that patients should have dietetic follow-up from the British Society of Gastroenterology. It's advocated that someone with specialist knowledge should be implementing the gluten-free diet. And actually, the European guidance advocates for a dietitian well-trained concerning celiac disease. So in terms of training and further post-registration training, what does that look like? Well, we had to look into that when we did our survey. It's worth noting that there's no sort of key numbers or anything, or numbers of dietitians sort of recommended within these guidance. So again, difficult to benchmark, difficult to make comparisons. So we found that the dietitians delivering these services are most frequently a band 6 or above, so they're likely to have significant clinical experience, but that differs in terms of post-registration training. We can see here that the majority of dietitians, vast majority, are receiving post-registration training in irritable bowel syndrome, if that's an area they're sort of delivering services in. But actually, this isn't the same for celiac disease and inflammatory bowel disease. And does this represent a gap for post-registration training for dietitians to further their skills and make sure we are delivering those services for patients with those conditions? Now, I had a gap in my slide, and thought, well, we'll get a nice picture of a dietitian training, but we all know what happens if you type dietitian into Google Images. We've got a nice lady in a white coat here eating a carrot. So, how do we fill these gaps in services within the constraints currently placed on the services? Well, trusts are consistently moving towards group education sessions, with a third of them delivering group education for celiac disease and irritable bowel syndrome, but actually only 1% were delivering services in groups for patients with inflammatory bowel disease. So is this an area that could be expanded upon? As we move more online, as we've had to today, these services may even be able to be delivered by webinar, as I'm sure we'll hear much more about later on, and this might even increase reach and capacity further. So in summary, there's a variation in dietitian numbers across England and a variation in access to specialist services and use of policy. There's long waiting times for patients with IBS, and even then, the time allocated to appointments might not be sufficient. Group education sessions are being utilised for some conditions. However, it's been really difficult to make comparisons because there's no clear guidance available or numbers available that we can make comparisons with, really. So what we need is national guidance to guide how much input is required to deliver effective services. And really what we need is to build a picture over time, and we need regular evaluation of these services and provision to make sure that we're building and growing our services in a way that meets the demand of the population. Thank you very much. Any questions?
Thank you for a fantastic talk there, Rachel. I'd just like to open the floor just for one quick question, if anybody have a question? If not, could I ask you a question, Rachel?
Yeah.
So how do you think people can use this data to improve their services?
I think in terms of this data, it's not really been looked at in a comprehensive way previously in terms of multiple conditions across the whole of the country. And I think what it starts is a benchmark, really. It's a starting point for us to evaluate services. We can clearly see that we need guidance there to determine how many dietitians are required. And without that guidance, it's really hard to make a clear assessment. So I think it really creates a sort of dialogue and opens the door for, using that information. Yes, it can be used sort of standalone by itself, but I think we really need a comparator to identify what services are providing sufficient services and what is, not adequate.
Thank you. One final question.
The thing is, Rachel, surely you have got demand. And that's a great starting point, isn't it? You've got overwhelming demand and a slide that shows that actually all the studies that we're discussing today, when you look at the amount of time involved, you're not able to provide that time. So I think it's a call to arms, that survey, to take that to your own local trusts and argue with your pointless managers and create jobs for dietitians and less jobs for managers. There's a thought.
Thank you.